Hi everyone, welcome to ResearchMD.com. We got a great presentation today. Let me introduce myself. My name is Dr. Pramil. Cheriyath. I'm a physician, practicing physician in the United States, program director, internal medicine residency, transitional residency, associate professor of medicine, 2 large medical schools. So we've been doing a series of lectures on endocrinology, right? We covered posterior pituitary. Now we are in the process of covering a lot of anterior pituitary hormones, and we talk about hypothyroidism. Yesterday we talked about the hyperthyroidism and the treatment. And today is a great topic today again. We're going to teach you everything about Graves' disease, my friends. Okay, you ready? All right, let's go. When you talk about Graves' disease, the number one thing you need to know, most common cause of hyperthyroidism in the world, okay? And then 20 to 50 per 100,000. Then you got the age, 30 to 50 years of age. That's what it peaks. And then ophthalmopathy in 50% in Graves' disease. So remember the word. When you talk about Graves' disease, think about ophthalmopathy. It's very important, the treatment and all of those kind of things, okay? And the pathogenesis is an autoimmune process. When we talk about pathogenesis, it's important to let's go back and visit our pathogenesis on those patients, okay? Now, when you look at the pathogenesis, let's look at how does it affect on the thyroid, and then we're going to talk about the pathogenesis in the ophthalmopathy, in the eye, what happens. So what happens, you got, again, this is an autoimmune disease. You got the thyroid antigen, dendritic cell, the antigen presenting cell that can activate the T cell and B cell, and B cell, the plasma cell, it produces this thyroid-stimulating antibodies. That's the most important thing, okay? And then then they come and join this thyroid receptor, TSH receptor actually. When you join the TSH receptor, what happens is you got cyclic AMP dependent signal, hypertrophy, hyperplasia, a lot of free T4, just like TSH, like overactivation, and a lot of free T4 and a lot of free T4 and T3s are produced. Okay, remember. So the main mechanism, you got thyroid stimulating antibodies. They come to this thyrotropin receptor and activate it. Now, you also have this T cell, and they produce interferon gamma, and then present expression of MHC class 2 over here, and that can causes a lot of damage over here, like hypertrophy and hyperplasia and all that. Now, it also activates a lot of cytokines, IL-12, IL-16, and all of this can cause hypertrophy, hyperplasia, and inflammation right here, okay? So remember that. That is the pathophysiology when you look about the thyroid. Okay, now let's look at what happens in the orbit, ophthalmopathy, right? That's the main thing we need to worry about Graves' disease. So when you talk about first, orbit get infiltrated with 3 things. You got T cell infiltration, B cell infiltration, CD34 fibrocyte infiltration. We need to know that. But the main mechanism, remember, you got B cell, then you got IGF-1 receptor antibodies production. They combine with IGF receptor, and the fibroblast got inflammation, all this happening, and you got hyaluronin production, glycosaminoglycan. That will lead to orbital fat and tissue expansion, which will lead to proptosis, optic nerve damage, okay? The other mechanism, when you talk about T cell, you got CD34 fibrocyte. They produce IL-1, beta, 6, 12, and 6, okay? And then with the resident CD34 fibroblast, you get downregulated to CD34 positive fibroblasts. And then again, this fibroblast can activate into production of hyaluronin glycosaminoglycan. Then also another mechanism is MHC antigen presenting cell bind with the thyroid antigen over here, T cell receptor, with the help of CD40 ligand and CD14, again kind of acts on the fibroblast and differentiate into adipocytes and myofibroblasts. Okay, and the adipocyte can cause this fat infiltration. That's the main thing you have to know that. But it's very important to those pathophysiology. Now we talked about the pathophysiology. Let's look at the clinical presentation. How does a patient present in the settings of Graves' disease? Constitutional symptoms, everybody know, right? Weight loss with increased appetite, and then you got heat intolerance, sweating, polydipsia, and then neuromuscular, you got tremor, nervousness, problem with the concentration, irritability, sleep disturbance, And cardiovascular patient present with the palpitation, tachycardia, they could cause like atrial fibrillation and systolic hypertension, remember. And then pulmonary can cause shortness of breath, tachypnea, and GI symptom, hyperdefecation, diarrhea, nausea, vomiting. When you talk about skin, they can have like a lot of perspiration, so the skin look like warm and moist, and then reproduction, the females always have this menstrual irregularities, okay? So those are the main symptoms. And also one thing we need to know, thyroid dermopathy is also, we have to be very careful about it. Pretibial myxedema, there is on the anterior shin, and you got usually like a non-pitting edema, okay? And then you got thyroid acropathy because of the clubbing of fingers and toes also can be seen in this setting. So those are the main findings we can see. Now, let's look at ophthalmopathy, like what happens. This could, the most important, it can actually, if you don't take care of it, it can threaten the eyesight. So it's very complicated, okay? So what are the signs and symptoms of the ocular involvement? You got symptoms of diplopia, irritation of the eye, eyelid swelling, retroorbital pain. The signs, proptosis 62%, eyelid retraction around 92%, that's very important. That's periorbital edema, conjunctival injection, chemosis, and you got ophthalmoplegia, 30% of the people. So most common start with usually eyelid retraction. That's probably the initial kind of thing, okay? Now, there is some severity index is important in the treatment. Eyelid erythema and edema, you give 1 point. Conjunctival injection, you give 1 point. You got coruncular swelling, you have 1 point. Chemosis, retroorbital pain, ophthalmoplegia, you all get 1 point. If it is 3 or greater, then it's like an active disease because it's important in the treatment. If it is stable or inactive, you calculate the score, and if it is stable, inactive, thing you have to do is like orbital decompression, fat removal, you got bony decompression of the lateral and medial walls, strabismus repair, and eyelid repair. Those are the things you do if it is inactive. You have the severity index, you calculate the score. If it is 3 or above, we know it's active disease, right? Then we have to put another category. It's a mild or moderate symptoms. And mild, if it is again, if it is score is 3 and 3 or greater, if it is mild active, you can use artificial tears, topical steroids, avoid and light smoke and elevation of head when you sleep, avoid eye cosmetics, important. Now, if it is moderate severe, that means when you calculate the score is greater than 3 and it's severe, moderate or active, you can do systemic steroid. Here, you're just doing like a topical steroids, okay? And then you give systemic steroids here, orbital irradiation, B-cell depletion, and emergency orbital decompression. Those are the treatment options we have available over here. Now, the next thing is our diagnosis algorithm. The first thing we have to make sure everybody knows the hyperthyroidism. There's going to be decreased TSH, increased free T3 and T4. And then you have to check the next important is TSH receptor blocking antibody. Okay, you check that. If it is positive, then pretty much this is Graves. Let's say if it is absent, then you have to go another test. You do the radioiodine uptake test, and then you got the diffuse uptake in the radioiodine, then Graves. What about thyroid ultrasound? When you do thyroid ultrasound, it could be like variable finding. If it is nodular, then you have to think about multinodal goiter. Okay, then you can rule out Graves' disease. Now, how do you treat it? Very, very important. So only 3 ways you can treat it. One is antithyroid drugs and the beta blocker. The next thing is radioactive iodine you can give, right? And then you can also give the option is surgery. Most of them is kind of specific to the patient-specific treatment, You can discuss with the patient all that. Let's talk about antithyroid drugs, very, very important. Propylthiouracil, PTU, okay? And then you got methimazole and carbamazepine. Always, first line is what? Methimazole. Always remember that. Why is that? Efficacy is good and long half-life. So you can do one dose per day. All the others, like you have to take like 2 doses and all that. So always first line treatment is what? Methimazole. Now, when you come to pregnant patient, first trimester, always you give PTU because the methimazole can be teratogenic. But second and third trimester, you can continue the methimazole. Okay, the like side effects of antithyroid medications. Okay, the main thing is skin rash is very common in these people, and you have to talk about like the other thing you have to talk about agranulocytosis, aplastic anemia, and then it can also causes like liver failure also in this group of people. Okay, but these are like rare causes and all that. Now the next thing is again beta blocker. We know like a symptomatic treatment, right? If it is COPD, just kind of make sure cardioselective beta blocker to control the tachycardia and all that. Now the other treatment is the radioactive iodine. This is probably the best treatment. It's completely curative, but the thing is like you have to take again lifelong supplement once with the hypothyroidism to treat it, right? So that's what's important. But if the patient have cancer or you're suspecting cancer, you should not be using radioactive iodine, right? Everybody know that, right? And then you can do like, if thyroidectomy, if it is again, the patient centered, if we got a large goiter, then, compressing symptoms, then you can use the thyroidectomy and then make sure like, you just, once you do that, you have to lifelong, as soon as the patient become hypothyroidism, you should start the thyroxine supplement or LT4, okay? Remember that. Those are the main things. So let's stand back and summarize the most important points in this presentation. Let's look at it. Now, we talk about the most common cause of hyperthyroidism. We talk about the pathogenesis and autoimmune pathogenesis, right? The main thing is you got this dendritic cell, thyroid antigen, activate T cell, BA cell activation, thyroid-stimulating antibodies, overactive thyrotropin receptor binding over here. You got hyperplasia, hypertrophy, increased hormone. That's you need to know. That's what's happening in thyroid. Now we're going to switch back to what happened. Most ophthalmopathy is like, very common in these people. So first you got the tumor cell, you got not tumor cells, you got the orbit get infiltrated with the T cell, B cell, and CD34 fibrocyte. Main mechanism we need to know, B cell activation, there's IGF-1, insulin growth factor 1. Always remember that. That get activated and then they go to the receptor binding fibroblast, a lot of hyaluronan, glycosaminoglycan, orbital fat, and all that too, okay? Now, we talk about the main symptoms. I think I'm not going to go into too much about the symptoms because we know the constitutional, neuromuscular, cardiovascular symptoms, but let's look at the orbital symptoms because it's very important. You can have diplopia, irritation of eye, eyelid swelling, or proptosis, eyelid retraction, and periorbital edema, ophthalmoplegia. Then you have to do risk stratification, severity index, give 1 point to all of this thing we kind of mentioned, and put them into 3 categories: mild active, moderately severe active, and stable. Always remember, if the score is 3 or greater, that's an active disease, and then you come up here and then you do this algorithm right here. First, you need to make sure the patient is hyperthyroid. That means decreased TSH, increased free T4 and free T3. Then you got thyroid receptor blocking antibodies check. If it is positive, then you know it's Graves' disease. If it is negative, you do the additional check of a radioactive iodine. You have refuse uptake, then you can say the patient got Graves. If you do an ultrasound, you will find variable findings. And then treatment, you got antithyroid drugs, you got beta blocker, and then always, radioactive iodine, and surgery is like curative treatment, and also make sure these people need lifelong supplement. Once it's curative, once they go into hypothyroidism, make sure you replace with levothyroxine, and don't forget the skin finding thyroid dermopathy, actually kind of like pretibial myxedema, it's non-pitting edema, and then cause clubbing of the fingers and all that. Thank you so much for watching. We'll be back with another presentation soon. Please subscribe to our channel. Please study hard. Thank you.